session. Welcome to you, sir.
श्वासप्रतिषेधं व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः यैरेव कारणे हिक्का बहुभिः सम्प्रवर्तते तैरेव कारणे श्वासो घोरो भवति लेहिनां. Shvasa is a breathlessness, and according to Sushruta, the same etiological factors which produce the hikka also can produce a shvasa. That means that there will be a abnormality of the gati of the prana and apana. Vihaya prakritim vayu prano asatapasanyutah shvasayati urdhavo bhutva tam shvasam prajakshate. When the normal passage of the vata, pranavata, is affected by the kapha, and then it tends to move upwards. That is considered as a shvasa. And the types are the Shudrakah, Tamakaha, Chinnaha, Mahan, Urdhvashta Panchada, Vidyate as a Mahavyadhi, Shvaso, Yako, Visheshadaha. Though the shvasa is considered as a single disease, based upon their clinical presentations and the course, it is considered again categorized into 5 categories: Kshudraka, Tamaka, Chinna, Mahan Shvasa, Urdhva Shvasa. The 5 categories are there. Prabhupam tasya hritpida bhakta dvesho arati para anaha parshyo shulam verastyam madana saja. The Pururupa are considered as a hritpida, that there could be a discomfort in the chest, in anorexia, and distress. Arati para is distress acid, distension of the abdomen, pain in the sides of the body, or vairastyam, that's a dislike for the taste acid, could be in the Pururupa. किंचित् आरभमाणस्य यस्य श्वासप्रवर्तते निषन्नस्य इति शान्तिं स क्षुद्रैः संविदः. Kshudrashvasa is a exercise intolerance. When a person is not able to do the normal exercises, and even after starting a relatively minor amount of the activity, when the patient feels breathlessness, that's considered as the Kshudrashvasa. Now, as far as from the current point of view, physiology point of view, the whole regulation of the respiration and the causes for a breathing difficulty can be many. Now, the regulation of the respiration is a very complex process which is mainly controlled by the hypoxic drive and mechanical drive. The hypoxic drive is if the concentration of the oxygen in the plasma is reduced, then the chemoreceptors, they get stimulated and they stimulate the respiratory center which is at the base of the brain, the central nervous system control. At the same time, mechanoreceptors from the skeletal muscles, they also would be stimulating the respiratory center whenever there is activity of the muscles. They are the main 2 important issues which make the respiratory control. In addition to these 2, the chemoreceptors and the mechanical receptors, the others are mainly the mechanical receptors present in the lungs or stretch receptors. When the lung expands to a certain extent, and when that expansion is a maximum, there will be an inhibitory response, so that the lungs do not get ruptured. So if the lungs expand to a maximum extent, then there would be inhibitory response to the respiratory center, and the respiratory center would be reducing the respiratory activity. So there would be mainly the respiratory center would have the inspiratory activity and the expiratory activity, or maybe stimulatory and inhibitory activity. When the lung stresses beyond a certain extent, then there will be an inhibitory activity, and that prevents the lungs from getting dilated beyond the normal extent and producing an injury. Whereas there would be also certain of the central chemoreceptors which are sensitive to carbon dioxide, and if the carbon dioxide concentration goes beyond a certain limit, then there would be stimulatory activity, or if the carbon dioxide goes below a certain limit, there will be an inhibitory activity which occurs through the central chemoreceptors. So these 2 are having both inhibitory and stimulatory activity, whereas the mechanoreceptors and peripheral chemoreceptors, they are having mainly a stimulatory activity, and the central respiratory center would have again at the base of the pons, you will have some more of the centers like pneumotaxic center, enuestic center. Pneumotaxic center is when it takes the breath, or it makes the person to take the air in. The inspiratory apparatus, the enuestic center is that center which keeps the lungs dilated, so that the duration of the air remaining in the lungs can be controlled, and this is under cortical control, as well as it is also having the subcortical controls, so that there is a partial involuntary as well as partial voluntary activity. Then the execution of these would be by the lower centers like dorsal centers and Brisney complex and ventral centers. They would be directly stimulating the respiratory muscles, and that how the muscles would be executing the activity as such, and ultimately they control the respiratory motor neurons. So that's how the respirator is controlled. The most important part is when the patient would have a dyspnea or breathlessness. The causes for breathlessness could be many. It may not be totally related to the primary respiratory center activity. Suppose if there is a reduced concentration of the oxygen in the blood due to any reason, like it may not just provide provision of the oxygen as such, even if the oxygen carrying capacity of the blood is reduced, as in case of anemia, or if the patient's circulatory system is affected and hence the blood is not circulating properly, and hence there is accumulation of carbon dioxide and oxygen concentration is lesser. In that situation, the carotid body gets stimulated, and that produces the increase in the respiratory activity. There is a tendency to put more effort during the respiration. Now, if it goes beyond a certain limit, that becomes a dyspnea. See, in a normal physiological control, if the concentration of the oxygen in the body reduces, then there would be a stimulation of the respiratory center, and the respiration becomes more deeper, as well as there would be a faster respiration, which is a normal physiological response. But if this physiological response goes beyond a limit, the oxygen concentration in the plasma is much lesser, not able to cope up with the metabolic needs of the periphery. In that condition, it presents as a dyspnea. So causes for the dyspnea could be a hypoxia, which is totally beyond that respiratory center even. Of course, the same is true if the oxygen supply is lesser, either in the environment where you are staying, like in hilly atmospheres, or when you are in a smoky conditions and so on, where the oxygen concentration could be lesser, or it also could be, the hypoxia also could be reduced due to reduced ventilatory activity. If the respiratory functions, muscles are not able to cope up with the activity, or there is a respiratory paralysis like condition, or if the chest cannot expand due to any reason, like a patient who has a pleural effusion, the lungs cannot expand, or a patient who has an injury in the chest, the lungs cannot expand. In that condition too, that can result in hypoxia. So hypoxemia can be presented both due to pulmonary as well as extrapulmonary causes, and this also would be presented as a respiratory difficulty or dyspnea. Now, a hypercarbia, that's if the carbon dioxide concentration in the plasma is increased. Of course, in any condition where there is a lesser ventilation, there would be hypoxia as well as hypercarbia. But at times there could be a situation like acidosis, metabolic acidosis, where the exchange of ammonia and the carbon dioxide and molecules is not proper. In that condition, like renal pathology, there could be accumulation of carbon dioxide, and that stimulates the central chemoreceptors, medullary central chemoreceptors, and that also produces the dyspnea. That again is the same situation. Up to a certain physiological limit, it just presents as a increased depth of the respiration as well as increased rate of respiration. But when it goes beyond a certain physiological limit, that presents with the breathlessness. And then, of course, if the the respiratory muscles are not really acting enough, or lung has become rigid, lung is not able to expand fully, in that condition, there again there could be more stimulation of the respiratory center, and all these factors put together, once the lungs are not expanded, there will be reduced oxygen concentration, there is a tendency for increase of build-up of the carbon dioxide, as well as because the oxygen supply itself is lesser, that would be the lungs muscles would not be stimulated properly, the stretch receptors in the lungs would be stimulating more of the respiratory center, there will be a increased breathlessness or breathing activity and breathlessness occurs. This occurs as in case of interstitial lung disorders, infective pathologies of the lungs and so on. Whereas airway resistance, the bronchial obstructions, if there is a obstruction to the respiratory tract, as in case of what we call as obstructive pulmonary disorder, uh, chronic obstructive pulmonary disorders, bronchial asthma, etc., where the airways they get constricted or edematous, there again there could be a breathlessness. Now, to define the breathlessness, you should be having some idea like what would be the normal volume of breathing and when we consider as a breathlessness. If the normal volume of the breathing is considered what we call as the tidal volume, which is around 500 ml in an adult, and this is the volume which is exchanged during both inspiration and expiration. Then you have a reserve volumes as such. The inspiratory reserve volume and expiratory reserve volumes are those volumes which can be volume of the air which can be taken in when there is a effort for inspiration or an effort for expiration. See, when you put all the effort to breathe in, the maximum amount of the air which can be taken in is called as inspiratory reserve volume, and the amount of the air which is expelled out with the effort is the expiratory reserve volume. Inspiratory and expiratory reserve volumes, they are depending upon the variable conditions like the previous training. A person like who does regular exercises with or sports persons, etc., they would have a vaster reserve volumes, whereas those who are obese, children, very old people, their reserve volume becomes lesser, and hence a person would feel breathlessness if the demand for the oxygenation is beyond the reserve volumes. See, as long as it is within the reserve volume, the demand is, suppose the demand for the supply could be, demand for the oxygen could be increased due to any of those factors which we have discussed earlier. But if that demand is within the limit, demand can be met within the limit of the reserve volumes, a person may not feel breathlessness or it may not be dyspnea. But if this is beyond the limit of the reserve volumes, then there will be a breathlessness. And the reserve volumes could be changing according to the physical condition of the person. A person who is having more physical activity, training and so on, the reserve volume will be more. So a similar amount of the pathology in a person who is having a lesser reserve volume may not produce the symptoms of breathlessness in a person who has a better reserve volume. Then there is another volume which we call as residual volume. Residual volume is the total volume of the lungs and the respiratory tract which cannot be expelled out. And this also counts particularly in assisted breathing. The total effort for the breathing would be, it is needed to overtake that residual volume, plus then you have to have either the tidal volume or the reserve volumes. And this is more important when you are on the ventilation, when you are putting the patient on ventilation. The total residual volume is the total volume of the lungs, or which is also called as the dead space of the lungs, which the amount of the air which cannot be expelled out in any condition. If at all you have to force the air in, like a ventilator, the amount of the air which has to be pushed in should be more than the residual volume. It should be, or the pressure of the ventilation should be more than the residual volume. So those who are obese, they would have a more of residual volume. Those who are less obese, they have a lesser residual volume. So that also adds to the total efforts of breathing. Now during the breathing, whether the air can be really exchanged in the lungs or not would be depending upon the pressure changes as such. So during the inspiration, there has to be a negative pressure created in the lungs, and the negative pressure would be around minus 80 millimeters of mercury. Minus 80 centimeters of water. Correction, it's not mercury, 80 centimeters of water. And with that negative pressure, the air can be sucked in. Suppose if the amount of the pressure created is lesser, suppose if it is less than 40, then the amount of the air taken in would be insufficient, and hence the person would always have a tendency to have breathlessness. minus 40 to minus 80 is considered as the safe pressures or the normal pressures as such, with which the physiological need for the ventilation can be maintained. Similarly, during the expiratory phase, there would be an increase in the pressure, and it's also considered to be around plus 80 centimeters of water, and during that phase the air which needs to be expelled out would be expelled out completely. If the pressure expiratory pressure is less than 40 centimeters of water, there again that also can produce a breathlessness, because the air cannot be expelled out. There would be increase in the total residual volume of the air, and that results in the symptoms of breathlessness. That's about one thing. Now, the breathlessness again could be a patient who has a breathlessness could be categorized mainly into three categories based upon the causes, and we categorize them as either obstructive or restrictive. Again, restrictive parenchymal and extra parenchymal. See, obstructive means when the air passage has become obstructed, and hence the pressure cannot be built up. The inspiratory pressure is not able to be built up. Like the inspiratory pressure, negative pressure is not created enough because of the obstruction. As well as in obstructive pathology, the air cannot be expelled out also. And in such condition, when the patient would be putting the more effort of inspiration, but even if after the inspiration, the amount of the volume of air which is taken in would be less than normal. See, this graph shows the normal line, whereas in an obstructive pathology, like whatever we say, these pulmonary obstructive conditions, because of the resistance of the airway resistance being more, the amount of the air taken in would be lesser, and amount of the air which is breathed out would be slower. The pressure has to be more, the expiratory reserve volume has to come into the picture, and accessory respiratory muscles also have to come into the action, so that the air can be breathed out. Now, in such conditions, the bronchodilators may help. In the obstructive pathologies, the bronchodilator drugs, commonly used drugs like bronchodilators, can help. Now, in the restrictive parenchymal disorder, restrictive extraparenchymal disorders, that means where the chest wall cannot expand, as in case of a respiratory muscle paralysis, thoracic injury, or maybe the pleural effusion, etc., where the total volume, the lung expansion capacity is lesser due to that external thoracic cage abnormality. The patient would be has to put in more efforts for breathing and expiration also. The amount of the total amount of the pressure or the amount of the air which is taken in as well as expirated out would be less than normal. In these conditions, bronchodilators cannot help. Bronchodilators do not help at all, and the amount of the exercise the patient has to put in would be more. So, in such conditions, the only option would be to increase the volume, this concentration of the oxygen in the air breathed in, to improve the condition, and not the bronchodilators as such. If you use the bronchodilators, the patient may become worse, because the patient cannot put more effort, or beyond this limit the effort cannot be put in as such. Restrictive parenchymal disorders, that's as the lungs cannot expand fully due to fibrosis, interstitial lung disorders, infective pathologies like bronchitis, pneumonia, etc., where the lung cannot, the thoracic cage can expand, but the lung itself has an incapacity to expand, as well as available air exchange, available area for the air exchange also is lesser. The patient has to put in more effort for inspiration as well as more effort for the expiration, but even with that effort, the amount of the volume of the air which can be taken in and taken out will be less than normal, and that in that condition, again, neither of bronchodilators nor of increasing the oxygen concentration in the air would help the patient. You have to ensure that the available area for the air exchange is enhanced. That's how it is considered. Now, as far as the pattern of the breathlessness seen in the clinical conditions, which could be due to either respiratory depression, and the respiratory depression could be presented with mainly the four types as such, like the Bayer's breathing, which is often seen in patients who have head injury or stroke-like conditions, where the cortical control, medullary control has become affected. And the pattern would be patient would have a increased volume of breathing, then there is a pause, and then there is somewhat irregular amounts of breathing. That not this increased volume of the breathing which is constant, then a pause, then again increased volume of breathing for a few breaths is what we call as a Boyart's breathing, with a phase of NUCs, like NUCs where the patient is not taking the breath at all, and pause as well. A change to, and this is often sign of improper medullary or cortical control, higher centers being affected, as in case of head injury, these stroke patients, etc. Now, chain strokes breathing is usually due to acidosis, which is a advanced state of respiratory failure. In that condition, the amount of the volume of the breathing starts with the relatively smaller volume, then increases, reaches a peak, then again comes down, and then there is a pause. And this is what called as a chain strokes breathing. That rhythm of the breathing would be a relative lesser volume, then increase in the volume, reaches a peak, then again it reduces, then there is a pause. That's called as a chain strokes breathing. Kussmaul breathing also is produced due to acidosis, where the total amount of the air taken in and taken out would be more, and the rate of respiration also would be rapid as such. Now, these would be like these two, where the conditions are there is a blockage, is exactly Chinna Shvasa, which is mentioned in Samhitas, and this is a Mahashvasa, the word Maha, the bigger, that's the Kussmaul's breathing. Now, exactly the same patterns can be seen. Then there is a superficial breathing, where there is a shallow. The total volume of the breathing is less than optimum and is not enough to maintain the ventilation, which is usually the end stage conditions. That's the superficial breathing. Then the other patterns which are critical. In addition to these, there could be the breathing pattern disorders could occur, either due to some psychological factors or simple external factors like mouth breathing, yawning, throat clearing, like patients who have something in the feeling like in the throat, irritation in throat, sighing, hyperventilation or hypoventilation could be again psychological origin, or certain may be difficulty in talking, fainting, sleep apnea disorder is another category which also is considered as a breathing pattern disorders, which are all the types of maybe the Kshudra Shvasa as such. Now, the typical features of that Tamaka and the other Shvasas mentioned in Sushruta are Tritsveda Vamathu Prayaha Kanta Gurgurukanitaha Vishesha Durdine Tamyat Shvasas Tamakomitaha. A Tamaka Shvasa is where the patient would present with the sweating and this obstructive feeling, that louder sound in the neck as such, and often occurs in cloudy weather. That's considered as Tamaka, which is typical of what we call as obstructive conditions, chronic obstructive pulmonary disorder like conditions. Ghoshena Mahaka Abishtaha Sakaponaraha Sashwasiti Abalo Annadvita Suktaha Tamaka Piditaha. Many times the Tamaka Shwasa patient would have a loud sound produced, and even cough and sputum also may be coming through, and the patient may not have a proper appetite. Sasamyati kafehine sapadascha vibardhare murcha dvara abhibhutasya neha pratamakastu saha. Such a patient would have a relief only when the sputum is expelled out, and the patient may feel better or feel worse when he lies down. Now, a dyspnea on lying down, or which is called as orthopnea, is often a sign of congestion in the lungs. If there is a fluid accumulated in the lungs, either due to cardiac pathology or it could be due to the inflammatory pathology of the lungs, when you lie down, the capacity, the area of the lung involved due to the fluid will be more. In the erect posture, the fluid will go to the gravitational dependent area, and only the base of the lung would be affected, and hence the patients of that category would have a relief in the sitting posture, and they would have worsening in the lying down posture. And that worsening in the lying down posture would be very remarkable if there is a cardiac pathology, because the fluid shift would be sudden and rapid. In the inflammatory pathology, the fluid shift may not be so rapid, but still orthopnea can occur. But a marked orthopnea is a sign of cardiac pathology, or pulmonary hypertension, where there is a increased fluid asset, and that's a sign of the Tamaka Shvasa, and that is considered as a Pratamaka. And if the patient has a orthopnea, Sushruta has categorized this as a Pratamaka, which is an advanced part of the Tamaka. आत्मातौ दक्ष्यमानेन बस्तिना सौजं नरः सर्वप्राणेन विच्छिन्नं श्वसति छिन्नं तमादिशेत. Chinna Shvasa is where the patient would have a glowing type of breathing, then there is a gap, and that is the Chinna Shvasa, which I have already mentioned, like chain strokes breathing or the Bayard's breathing. निसन्यः पार्श्वशूलात्मः शुष्ककण्ठो अतिघोषवान् समृद्ध नेत्रः आयम्य यश्वस्यात् महान् स्मृतः. महान् श्वासा, as in case of that the respiratory failure conditions, the patient would have impaired consciousness, and there could be even the pain that this oral cavity would be dry, and the patient's eyes would be just looking upwards, sign of a failure, respiratory failure, which is in the Kusuman's breathing. Marmasu ayamyamaneshu shwasan mudho muhushche saha urdhupilakshi hataravah tam urdhashwasam adisheta. Urdhashwasa is the fatal situation where there is a respiratory failure and the patient would be having impaired consciousness, eyes will be looking upwards, and the total amount of volume exchanged also would be lesser. That's the shallow breathing, which is often sign of a fatal condition, end stage condition. क्षुद्रः साध्यः साध्यतमः तेषां तमकः कृच्छ्र उच्यते. त्रयश्वासः न सिद्ध्यन्ति तमको दुर्बलस्य च. Kshudrashvasa is easily curable because the patient would have dyspnea on exertion, and which are usually due to those different causes other than that of the primary respiratory pathology. Only the exertion could be the cause as such, and either you can regulate the exercise or maybe conditioning of the patient. Regular exercises would help the patient for recovery. And as in case of these psychological hypoventilation, etc., some suggestions, counseling often could be enough to treat the condition. Whereas Samakashwasa, which is obstructive pathology, is difficult to be treated, whereas the other three are considered as asadhya according to Shruta. Of course, they are asadhya if you do not have a capacity to either supplement of oxygen or maybe increasing the volume of respiration, ventilation. Either assisted ventilation is necessary or a supply of oxygen would be necessary to make the patient survive. The protocol of the treatment is Snehabastim Vina Kechit Urdhum Chadhascha Shodaram Mrudu Pranavatam Shreshtam Shwasinam Adishantija. In general, the protocol of the treatment for the Shwasa is Urdhva Adhashodhana, that's Vivechana and the Vamana according to the condition, and Snehabasti is not to be given in such conditions. That is the general line of the treatment. Shwase kase cha hikkayam hridroge chapi pujitam hridam puranam sansidam abhaya vidara mathaihi. The general, one of the common prescription in all Shwasa, Kasa and Hikka as well as Hridroga would be Purana Ghrita with the Abhaya and Hingu. Sarvachala Abhaya Vilvehi Samskritam va Anavam Ghritam Pipalyad Prativapam Siddham va Prathame Gane Sapanja Lavanam Sarpihi Shwasa Kasu Vepohati. Another of the yoga, Savarchala Bhaya with the Purana Gata and Pipalayadi Prativapa. Then Himsra, Vidanga, Pudika, Tripala, Vyasisitakahi, Brikshiram, Sanitam Sarpihi, Chaturguna Jalapratam, Kolamantri, Pivetanti, Shwasakasa Vepohati, Arshamsi, Arotikam, Gulmam, Shakrat Vedam, Shayam Tata, Kristane, Rushakashaye, Pa, Pate Sarpihi Chaturgune, Tanmula Kusuma Vapam, Shitam, Shautrena Yodeta. Another of the yoga, where a Kshirapaka is prepared and then it's also administered with the Kshaudra, that's honey, that's it also is useful in case of Arsha, Arotika, etc. Vrishakashaya, that's Vasa Kashaya, with the ghee is prepared, and with Vasa Pushpa, the flowers of the Vasaka also can be given in the Kshaudra. Shringi, Madhu, Madhulika, Bharmi, Shunti, Taksha, Sita, Ambudehi, Saharidrihi, Swashehi, Sameha, Avapi Yogataha, Kritaprastam Patet Bhiman, Shita Doye Chaturgune, Shwasam, Kasam, Tatha, Hikam, Sarpi, Etan Yachati. Another of the Grita Prayoga which can be used for the Shwasa. Suvaha, Karika, Bhargi, Shukaksha, Naichilam Palam, Kakadani, Shungaveram, Varshabhu, Brihati Dvayam, Kolamatre, Gripaprastam, Pachet, Epi, Jalakvikam, Katusnam, Pitam, Etati, Shwasamaya Vinashanam, Sauvarchala, Yavakshara, Katuka, Vyosachitrakaihi, Vacha, Abhaya, Vidangesha Satisam, Shwasashantaye, Gopavalli, Udake, Siddham, Syat, Anyat, Bigune, Ghritam. Now, the another of the yoga which can be used for the Shwasa. Panjaitani Havim Shyahu, Vishaja Shwasakasiyoho. The same combination also can be presented as 5 different yogas as such. तालीश तामलकी उग्र जीवंती कुष्ठसैंधवैः बिल्व पुष्कर भूतिक संवर्चर कणाग्निभिः पथ्या तेजोवती युक्तैः सर्पिः जलचतुर्गुणं हिंगु पादयुतं सिद्धं सर्वश्वासहरं परं वासाघृतं षट्फलं वा घृतं चार्थहितं भवेत् योग तालीशाधिकृत तैलं दशगुणे सिद्धं भृंगराजरसे शुभे सेव्यमानं यथा न्यायं श्वासकासं व्यपोहति भृंगराजरस प्रिपेर्ड तैल also is another of the yoga. Phalamlaha, Vishkidarasaha, Snigdaha, Pravyakta Sindavaha, Yenadinam Shirobhirva, Kaulathaha, Susamskradaha, Hanyam, Shwasam Tekasantya Sanskudane Payamsja. Another of the yoga where Phalamla and the soups of different animals like Eda is a deer's head and with the Kulatha as a complicated yoga. तिमिरस्य बीजानि कर्कटाख्या चूर्णिरा दुराराधा अतः पिप्पल्यः कटुकाख्या हरितकी श्वाविन् मयूररोमाणि कोलाः मागधिकाकणाः भार्गीत्वक् शृङ्गवेरच्च शर्करा शलकाग्रजं नृत्तकौण्डकबीजानि चूर्णितानि तु केवलं पञ्चश्लोकार्धिकास्त्वेतो लेहाः ये सम्यग् सर्पिर्मधुभ्यां ते लेह्यः काशश्वासार्धिकैः नरैः. Another set of the yogas of 5 yogas where each line would be one of the yoga. Saptachadasya pushpani pippadischaphi mastana pibet sanchurne mudhana dhanascha api athapakshayet. Saptachada pushpa is another of the general suggestion. Arka ankureihi bhavitanam yavanam sadhanekashaha tarpanam va pibedesham sakshaudram shvasapeditaha shirisha kadali kandapushpam kadali kundapushpam magadhikayutam Tandulamritam Pitva Jayet Shwasan Asheshadaha. Another of the yoga which can be used for Shwasan. Kolamajam, Talam Mulam, Rishya Charmam Asim Vishya Chaudrena Bhangincha Sarpihi Madhusamayitam Niji Kadamba Bijabtva Shakshaudram Tandulambana Haridram Maricham Draksham Gudam Rasnam Padam Shatim Vishya Tailena Tulyani Shwasartho Hitabhojanaha. Some more of the yogas related to the same. Gavam Purishaswarasam, Madhusarpikarayitam, Vishyat Shwasesu Kashesu Vajinama Shatradrasam, the Gomaya Swaraka with the Madhu and Sarpi, or the horses done, the juice extracted from that also is suggested. Pandarogeshu Shoteshu Yoyogeha Samprakirtidaha Shwasakasapahate Kasagna Yajaprakirtidaha. The yogas which are mentioned in the Pandu and Shotha also can be used in the Shwasakasa, particularly orthopnea-like conditions, cardiac origin conditions, pulmonary hypertension conditions. Bhargitpaka Trivshanam, Tailam, Hridram, Kadrohinam, Pippalim, Paricham, Chandam, Boshakrat Samayamata. Another of the combinations. Talakota Sibijeshu, Bhajed Utkarikam Shubham, Sevemanaha Niyantesha, Shwasan Ashu Sudustharan, Purana Sarpihi, Pippalyaha, Kaulathaha, Zangara Harasaha, Sura, Savirakam Hingum. Matalunga Madhu, Draksha, Amalaka Bilwani, Shastani, Shwasi, Kinam, and the other Pathyas. Swinnam, Jnapatashchenam, Bhojaitwara Sodanam, Vatashleshu Vibandeva, Bishak Dhumam Prayojator, Manashira, Devadaru, Haridra, Chadanas, Amishehi, Laksha, Urubukamule, Shakritva, Varti, Vidhantaha, another Varti which could be used for the Shwasa. Shringabala, Kurasnai, Pakas Gavamavi, Dete Sarva, Selfishka, Thuma, Karya, Janata, Dhumapana, and Varti. The earlier yoga also for Dhumapana and Varti. Baliyasi, Kaphagraste, Vamanam Sabirechanam. If there is a severe kapha, then Vamana and Virechana can be given. Durbaleji, Varukshet, Tarpadam Hidam Chete, Dangala, Urabraji Himansi, Anupaiva, Susanskati. If the patient is very weak and the body is right, in such condition, Tarpana with the Mamsarasa are suggested. Yatha Agnihi Iddha Pavananaviddo Vajram Yatha Surajamuktam Rogat Vaive Kaludurnibaraha Shvasascha Kasascha Vilambikacha. Shwasa Kasa Vilambika, these diseases are very difficult to be treated because they are presented with the impairment of the Agni, and Sushruta compares it to the history, this or epical story of Indra Ayudha with the this Himavan, this yeah, which has now become hill-like. Himavan, according to the story, due to being hit by the Vajrayuda of Indra, the Himavan became a mountain and he is not able to move. Similarly, Shvasakasa Vilambika, these disorders can remain for a long duration and hence they cannot be treated easily and they become difficult to be treated. With this, it is Sushrutamitaam Uttaratantrāntratve Kaya Chikitsa Tantre Hikka Shvasapratishedha Nama Trayodashadhyaha Ekapanchashtamodhyayaha. In the clinical field dealing with the breathlessness, that differentiation between the breathlessness produced due to pulmonary, the extrapulmonary causes, interstitial lung disorders, restrictive and obstructive pathologies, they have to be made out by the clinical assessment, and the treatment has to be successful. Treatment is followed when those principles are adopted. With this we will conclude. If there are any questions, okay, there are no questions, so we will wind up. Thank you.